Welcome. In this session, we'll be discussing about intraocular pressure. Although intraocular pressure is a part of clinical evaluation of glaucoma patients, or for that matter, a part of routine ophthalmic examination, we'll be discussing intraocular pressure separately before going into clinical evaluation for glaucoma, because intraocular pressure in itself is a big topic, as there are a large number of physiological and pathological factors which may influence intraocular pressure, and there are also a large number of techniques to measure intraocular pressure. We'll be discussing Goldmann, Applanation, tonometry in detail, but for the remaining techniques of measuring intraocular pressure, we'll be discussing their underlying principles with simplified diagrams and their pros and cons in specific clinical scenarios. Aqueous humor dynamics is the study of the parameters which can affect intraocular pressure. Study of these parameters is important because intraocular pressure is still the only risk factor towards which all the currently approved therapy for glaucomatous optic neuropathy are directed, and intraocular pressure can be reduced only by modulating these parameters. The modified Goldmann equation defines the relationship of intraocular pressure to the parameters which determine it in the steady state. So in the Goldmann equation, we can keep the pressure parameters on the left side of the equation and the flow parameters on the right side of the equation. The pressure parameters are the intraocular pressure and the episcleral venous pressure in millimeters of mercury, and the flow parameters are the rate of aqueous humor formation in microliters per minute, which is also equal to the rate of total aqueous humor drainage in the steady state. U is the rate of Uveoscleral outflow in microliters per minute, and C is the trabecular outflow facility in microliters per minute per millimeter of mercury. Trabecular outflow facility is the inverse of trabecular outflow resistance. So F minus U represents the rate of trabecular outflow. The modification in the original Goldmann equation is the introduction of the U factor representing Uveoscleral outflow, which was not present in the original Goldmann equation. Rate of aqueous humor production is estimated to be 2 to 3 microliters per minute in awake state and decreases by half during sleep, and this sleep wake difference contributes to the diurnal variation of intraocular pressure, which we will be discussing in more detail in this session. Turnover of aqueous humor in the anterior chamber is said to be 1% per minute, or in other words, the total amount of aqueous humor at any point of time can be exchanged in 100 minutes. The rate of aqueous humor production cannot be determined directly experimentally, but at steady state, the rate of aqueous humor formation is equal to the rate of total aqueous humor drainage, including both trabecular and uveoscleral outflows, and this rate of total aqueous humor drainage can be measured by fluorophotometry, in which topical fluorescein is instilled on the eye, and the decline of the concentration of fluorescein in the anterior chamber over time is measured optically, from where rate of drainage can be calculated, which is equal to the rate of aqueous humor production. Rate of aqueous humor production in the ciliary body is determined by blood flow to the ciliary body, integrity of the blood aqueous barrier, and neurohumoral regulation of these two parameters. And factors which can influence these two parameters and reduce aqueous humor production include sleep, older age, drugs such as general anesthetics and systemic hypotensives, ciliary body inflammation and trauma, carotid occlusive disease, and aqueous humor suppressants. Trabecular outflow facility is the inverse of trabecular outflow resistance, as we have mentioned, and it varies between 0.2 to 2.30 microliters per minute per millimeters of mercury in normal eyes. Trabecular outflow facility decreases with age, and it can be altered by surgery, trauma, and medications. In primary open-angle glaucoma patients with elevated intraocular pressure and in individuals with ocular hypertension, the outflow facility decreases, chiefly at the level of juxtacanalicular meshwork and the inner wall of the Schlemm canal, as we have discussed in a previous session, and is very important to remember. Outflow facility can be determined by an experimental method called tonography, which has limited accuracy and is thus rarely used clinically. In this method, a weighted sheared tonometer or a pneuma-tonometer is placed on the cornea to acutely elevate the intraocular pressure. The subsequent rate of decline of intraocular pressure over time is used to calculate the outflow facility. The normal range of episcleral venous pressure is 6 to 9 millimeters of mercury, and episcleral venous pressure can be measured by venomanometry, in which the amount of pressure which needs to be applied on an episcleral vein to collapse it is measured. Since episcleral veins are the final drainage site of trabecular outflow pathway, intraocular pressure of an eye with intact aqueous humor production cannot fall below this level. So an intraocular pressure of 5 mm of mercury or less suggests failing aqueous humor production or ciliary body shutdown, and this is important to remember. Episcleral venous pressure increases with supine posture and increase in systemic blood pressure. Episcleral venous pressure increases in Sturge-Weber syndrome, carotid cavernous fistulas, cavernous sinus thrombosis, and thyroid eye disease. ROCK inhibitors, a recently introduced anti-glaucoma medication, can decrease intraocular pressure by decreasing episcleral venous pressure, and raised episcleral venous pressure can cause reflux of blood in the Schlemm's canal, which may in turn alter outflow facility. Uveoscleral outflow cannot be measured directly non-invasively, and it is estimated from the Goldmann equation by measuring the other parameters. Uveoscleral outflow is said to decrease with increasing age and in patients with primary open-angle glaucoma. Uveoscleral outflow is increased by prostaglandin F2 analogs, and this is the main mechanism by which prostaglandin F2 analogs decrease intraocular pressure. Uveoscleral outflow is also increased by cycloplegics, adrenergic agents, cyclodialysis clefts, and suprachoroidal stents, and uveoscleral outflow is decreased by myotics. The effects of cycloplegics and myotics on uveoscleral outflow is opposite to their effects on trabecular outflow, which is increased by myotics and decreased by cycloplegics. Increase of uveoscleral outflow by cycloplegics and decrease of uveoscleral outflow by myotics are secondary to the effects of these drugs on the ciliary muscles, and is important to remember. As we have discussed in the previous sessions, IOP is a continuous risk factor for glaucoma, and there is no safe level of intraocular pressure below which glaucoma does not occur. And there is no cutoff which distinguishes glaucomatous patients from non-glaucomatous individuals, so intraocular pressure is not included in the definition of glaucoma. And it has been estimated that using an IOP cutoff of 21 mm of mercury to define glaucoma can miss up to half of all glaucoma patients. Even then, intraocular pressure is the only risk factor towards which all currently approved treatment strategies for glaucoma are directed. Mean IOP in European population has been estimated to be 15.5 mm of mercury with a standard deviation of 2.6 mm of mercury, and the population distribution of intraocular pressure in individuals between 40 to 80 years of age is found to be non-Gaussian with skewing to the right. That means more individuals are towards the higher side of the mean than individuals towards the lower side of the mean. There is little variation of intraocular pressure with age in normal individuals, and this is because both aqueous humor production and trabecular and uveoscleral outflow facilities decrease with age. Intraocular pressure is affected by body position and is found to be minimal in the sitting posture with the neck in neutral position, and intraocular pressure increases with supine position due to increase in episcleral venous pressure. Factors which may increase intraocular pressure include bending, breath holding, Valsalva maneuver, tight collar, eyelid squeezing, fever, hypothyroidism, and drugs and procedures. Among drugs and procedures which increase intraocular pressure, we have anticholinergics, steroids, ketamine, depolarizing muscle relaxants such as succinylcholine, topiramate, and intubation as compared to laryngeal mask anesthesia. Ketamine is preferred for examination under anesthesia of patients with congenital glaucoma, as it does not reduce intraocular pressure like other general anesthetics. And in open globe surgery under general anesthesia, succinylcholine should be avoided as a muscle relaxant because it increases intraocular pressure, thus tending to cause prolapse of intraocular contents. And factors which may decrease intraocular pressure include aerobic exercises, pregnancy, acidosis, and drugs such as alcohol, general anesthetics except ketamine, and non-depolarizing muscle relaxants. There is a circadian rhythm called diurnal variation of intraocular pressure. In non-glaucomatous individuals, intraocular pressure varies by 2 to 6 millimeters of mercury in a 24-hour period, and this figure is important to remember. And it has been found the higher the mean intraocular pressure, the larger the diurnal variation. In glaucoma patients, the diurnal variation is larger and is usually found to be more than 10 millimeters of mercury. Larger the diurnal variation, greater is the risk of glaucoma progression in glaucoma patients. And diurnal variation has been found to decrease more after surgical treatment of glaucoma than after institution of medical therapy for glaucoma. The time of peak IOP depends on individual behavior, with the normal pattern of supine position at night time and upright position in daytime. Peak IOP is usually found in early morning hours or immediately after waking up, and this is also important to remember. The occurrence of peak IOP during early morning hours is found in both normal individuals and glaucoma patients, and this diurnal variation occurs due to changes in aqueous humor production and trabecular and uveoscleral outflow over 24-hour periods. And diurnal variation may explain progression of glaucoma despite apparent good control of IOP when patients are examined during clinic hours in the daytime. As we have mentioned, there are a large number of techniques and devices to measure intraocular pressure. Although Goldmann Applanation tonometry is still considered to be the gold standard in measuring intraocular pressure, apart from Goldmann Applanation tonometry, the other methods do not require the examiner to determine the endpoint of measuring intraocular pressure, and thus potentially eliminates one source of error. So the term tonometry means non-invasive measurement of intraocular pressure. Applanation tonometry is based on Imbert-Fick principle, which states that the pressure inside a dry thin sphere is equal to the force required to flatten it divided by the area of flattening. But the cornea is neither dry nor thin, and we'll see how applanation tonometry techniques, particularly Goldmann applanation tonometry, circumvents this difficulty. Goldmann applanation tonometry is the most common method of measuring IOP and is still considered the gold standard of measuring IOP. In Goldmann applanation tonometry, the force required to flatten an area of 3.06 mm is measured. When the area of flattening is 3.06 mm, the outward force due to corneal rigidity from the thickness of the cornea neutralizes the inward force from the surface tension of the tear film. So an area of 3.06 mm takes care of the two factors, corneal thickness and the tear film, which contradict the prerequisites of the Imbert-Fick principle. As Goldmann applanation tonometry does not displace significant amount of intraocular fluid, it is not affected significantly by ocular rigidity, which affects indentation tonometry with Sheard's tonometer. The Perkins and Draeger tonometers, the Perkins tonometer being shown in this photograph, are similar to Goldmann applanation tonometer in principle but are portable and can be used on a patient in supine position. For Goldmann applanation tonometry, local anesthetic is first applied on the eye and optimum quantity of fluorescein is instilled. So both excessive and inadequate quantities of fluorescein can affect IOP recording, as we will be discussing. The tip of the Goldmann applanation tonometer is used to flatten the cornea, and the image of the fluorescein encircling the flattened area is split by the biprism in the tip of the instrument. The biprism is located here on the tip of the Goldmann applanation tonometer. The fluorescent semicircles thus created by the biprism is observed with cobalt blue filter of the slit lamp, and these fluorescent semicircles are called Myers. The Myers should be optimally thick, and appropriately positioned so that the shape of the two myoids are symmetrical. The myoids will be seen to oscillate horizontally with ocular pulsation. Then the force adjusting dial is rotated to horizontally move the myoids. The endpoint of adjustment where the IOP is measured is where the inner ends of the myoids touch each other at the midpoint of their oscillations. So in this diagram we see that the inner ends of the two myoids represented in green touch each other, and the white arrows denote their horizontal oscillation with ocular pulsation, and the value of force indicated by the dial in gram force or dynes is multiplied by 10 to obtain the intraocular pressure directly in millimeters of mercury. There are numerous factors affecting applanation tonometry. Thicker tear films result in overestimation of IOP by reducing the inwardly directed surface tension of the tear film, and thinner tear films result in underestimation of intraocular pressure by increasing the inwardly directed surface tension of the tear film. Inadequate amount of fluorescein underestimates intraocular pressure, and excessive amount of fluorescein may overestimate intraocular pressure. So in this diagram we see thick myoids due to excessive fluorescein, and in this diagram we see very thin myoids due to inadequate fluorescein. And asymmetrical positioning of the myoids as seen here in this diagram can lead to erroneous measurement of intraocular pressure. And to make the myoids symmetrical, vertical and horizontal adjustment of the microscope arm of the slit lamp needs to be done. Corneal thickness is considered to be a very important factor in determining the accuracy of intraocular pressure recording by Goldmann Applanation tonometry. Goldmann Applanation tonometry gives the most accurate IOP reading with central corneal thickness of 520 microns. Thicker corneas overestimate intraocular pressure as thicker corneas resist deformation of the cornea, and thinner corneas lead to underestimation of intraocular pressure. So intraocular pressure may be underestimated after keratorefractive procedures like LASIK and PRK, as these procedures ablate the cornea and reduces the thickness of the cornea. The relation between central corneal thickness and measured intraocular pressure is nonlinear, so suggested correction factors to modify the measured intraocular pressure in order to obtain the actual intraocular pressure are not always accurate. And according to ocular hypertension treatment trial, thinner corneas increase the risk of progression to glaucoma in individuals with ocular hypertension, and this is very important to remember. And this may result either from underestimation of intraocular pressure, or a thinner cornea can be an independent biomechanical risk factor. Corneal astigmatism greater than 3 prism diopters can influence the accuracy of intraocular pressure recording with Goldmann Applanation tonometer because it leads to elliptical or irregular shape of the myoids, and the error can be reduced by orienting the red mark on the tip of the instrument along the flattest meridian of the cornea, or by taking the average of two readings with the prism rotated 90 degrees apart. Corneal edema can lead to underestimation of intraocular pressure, and corneal scarring and stiffening can lead to overestimation of intraocular pressure by Goldmann Applanation tonometry. So the corneal factors which can influence the accuracy of intraocular pressure recording with Goldmann Applanation tonometry include corneal thickness, corneal astigmatism, corneal stiffening, corneal edema, and corneal scarring. Other factors which can influence the accuracy of IOP reading with Goldmann Applanation tonometry include eyelid squeezing by the patient, pressure on the globe by the examiner while holding the eyelids apart, Valsalva maneuver by the patient, particularly in case of obese patients attempting to lean forward to reach the slit lamp, technical errors in measuring intraocular pressure such as asymmetrical myoids or the inner ends of the myoids not touching each other, and inaccurately calibrated tonometer. Calibration of the tonometer should be done twice every year. To calibrate the Goldmann Applanation tonometer, a calibration rod, also called the check weight, is provided with the Applanation tonometer, and it has one 0 mark, a couple of 2 marks, and a couple of 6 marks. The calibration rod is attached to the axis of the tonometer with an adjustable holder, with one of the marks aligned with the axis and the longer segment of the rod directed towards the examiner and the shorter segment of the rod directed towards the patient. When the zero mark is aligned with the axis of the tonometer and the dial of the tonometer shows a reading of 0 mm of mercury, if the calibration of the tonometer is adequate, the arm of the tonometer should freely move forwards and backwards when the tonometer dial is rotated clockwise or anti-clockwise by half a mark, that is 1 mm of mercury. And this free backward and forward rocking movement of the tonometer arm should also occur when the 2 mark and the 6 mark of the calibration rod is aligned with the axis of the tonometer and the tonometer dial shows a reading of 20 mm of mercury and 60 mm of mercury respectively. So calibration is said to be adequate when the arm of the tonometer shows free backward and forward rocking movement in all three settings, with 0 mark of the calibration rod aligned along the axis of the tonometer with 0 mm mercury reading of the tonometer dial in the first setting, with the 2 marks of the calibration rod aligned along the axis of the tonometer and 20 mm of mercury reading on the tonometer dial in the second setting, and with the 6 marks of the calibration rod aligned along the axis of the tonometer and 60 mm of mercury reading on the tonometer dial in the third setting. Mackay-Marg and Pneuma-tonometer are also Applanation tonometers, and in certain situations they offer an advantage over Goldmann Applanation tonometer. Mackay-Marg tonometer has an electronic microplunger from which the force is recorded protruding from a surrounding footplate. During the procedure, initially only the microplunger pushes the cornea and there is a sharp increase in the force recorded from the microplunger. But when the microplunger becomes flush with the footplate shares some of the force from the cornea and the force recorded from the microplunger decreases, followed by increase in the force recorded from the microplunger when both the microplunger and the footplate pushes the cornea further. The force recorded at this trough point when the microplunger just becomes flush with the footplate represents the intraocular pressure, because at this point there is optimal applanation of the cornea. Tonopen, as shown in this photograph, is a Mackay-Marg tonometer and it contains a strain gauge at the center of the tip as the transducer. The tip of the device is gently pressed against the cornea till several readings are taken by the device and the machine gives the final IOP measurement with the coefficient of variation. Since the area of applanation with Mackay-Marg tonometers is very small, approximately 1.5 mm, Mackay-Marg tonometers give more accurate readings in patients with corneal scarring and corneal edema, as the tip can be placed in a normal area of the cornea, and Mackay-Marg tonometers can be used for a patient in supine position. Pneuma-tonometers are also applanation tonometers and have an air-filled chamber through which air continuously flows, a hollow probe inside the air-filled chamber, a silastic membrane in front of the probe, a transducer to measure the air pressure inside the chamber, and side vents to allow the air to escape. As the probe with the silastic membrane applanates the cornea, the side vents get closed and the pressure within the chamber increases. And this increased pressure, as measured by the transducer, represents the intraocular pressure. Like Mackay-Marg tonometers, since Pneuma-tonometers have a small tip, it can give more accurate results in eyes with corneal scars and edema as compared to Goldmann Applanation tonometer, and it can also be used for a patient in supine position. And it has been seen that IOP recordings with the Pneuma-tonometer taken from the sclera and the cornea correlate with each other, and Pneuma-tonometer thus can be useful for measuring intraocular pressure in eyes with keratoprosthesis. And Pneuma-tonometers can record pressure continuously and so can be used for tonography to measure outflow facility, and can also analyze ocular pulse amplitude, which is the difference between the intraocular pressure in the systolic phase and the intraocular pressure in the diastolic phase of the cardiac pulse. In non-contact tonometry, a puff of air is used to indent the cornea, and the force of this air puff is recorded when the light reflection from the indented area of the cornea is maximum, and from this force of the air puff, the intraocular pressure is measured. Non-contact tonometers do not require local anesthesia and offer a minimal risk of cross-infection, and so they can be used in large screening programs. Compared to IOP recorded with the Goldmann Applanation tonometer, non-contact tonometers overestimate intraocular pressures, and this is very important to remember. And the overestimation is more with higher intraocular pressures measured with Goldmann Applanation tonometers. Ocular Response Analyzer and Corvis ST can also perform non-contact tonometry in addition to evaluating corneal biomechanical parameters. Ocular Response Analyzer uses an air puff to indent the cornea and takes two recordings when the cornea is indented, once when the cornea is being pushed in with rising force of air and once when the inwardly deformed cornea rebounds externally as the force of the air puff decreases. The detector of the ORA detects flattening of central 3 mm of cornea. ORA gives a cornea compensated IOP which is said to be less influenced by corneal biomechanical parameters. And this cornea compensated IOP shows a stronger correlation with progression of glaucoma as compared to GAT determined IOP. ORA also gives corneal hysteresis, a corneal biomechanical parameter, and it has been shown that lower corneal hysteresis is associated with development and progression of glaucoma as well as keratoconus. And ORA has been found to be useful to determine intraocular pressure and risk of ectasia following keratorefractive surgery. The Corvis ST uses air puff to indent the cornea, and a shine flag camera detects indentation and rebound of 8.5 mm of cornea. The Corvis ST gives a biomechanically corrected intraocular pressure which is found to be less affected by corneal biomechanical factors and can reliably measure intraocular pressures after refractive surgery. We will be discussing more about corneal biomechanics in the section on cornea. The eye care tonometer has become quite popular and is a rebound tonometer. In rebound tonometry, a very small probe is propelled forward to impact the cornea, and after impacting the cornea, the probe rebounds backwards, and the velocity of the reverse movement varies with the intraocular pressure. The velocity is measured by a magnet in the probe passing through a solenoid coil. This measured velocity is used to estimate the intraocular pressure. Unlike other contact tonometers, rebound tonometers do not require local anesthesia and is thus useful in children. This photograph shows an eye care tonometer, and these tonometers can be used for patients in supine position, and accuracy of rebound tonometers have been found to depend on corneal thickness, and one version of the eye care tonometer has been marketed for home-based autotonometry, but accuracy depends on centration of the impact of the probe on the cornea. Dynamic contour tonometry is a contact tonometry technique but without either applanating or indenting the cornea. So in DCT, the cornea is neither flattened nor indented, and Pascal is the available dynamic contour tonometer. The tip of the dynamic contour tonometer resembles the tip of the Goldmann Applanation tonometer externally but is actually concave with a pressure sensor in the center of the tip. And during contact with cornea, the tip exerts a constant force of 1 gram. The DCT is based on the principle that when the cornea takes up the shape of the concave tip, which is called contour matching, the cornea becomes tension-free as the radial and bending forces acting on the surface of the cornea no longer act when the cornea is in contact with the concave tip. And then the pressure on the inner and outer surfaces of the cornea becomes same, and the pressure on the outer surface of the cornea is then measured by the sensor in the tip of the DCT. DCT requires 8 to 10 seconds of contact with the cornea, so a cooperative patient is a prerequisite for DCT, and the device measures the pressure 100 times per second during this contact. DCT has been found to give highly reproducible IOP measurements, and the IOP measurements by the DCT is said to be less affected by biomechanical parameters. But the IOP recorded by DCT has been found to be higher than IOP recorded by Goldmann Applanation tonometers. DCT requires an anesthetic but does not require fluorescein, and DCT can measure ocular pulse amplitude, and the IOP reading shown by the device is the average IOP during the diastolic phase of the cardiac pulse. The bioresonator RT is an Applanation resonance tonometer which measures both the area of the applanation and the force applied on the cornea. The device has a piezoelectric element attached to a convex tip and a force sensor. As the tip touches the cornea, the area of contact is measured from the change of resonance frequency of the piezoelectric element, and the intraocular pressure is calculated from the area derived from the change in resonance frequency of the piezoelectric element and the force measured by the force sensor. Accuracy of IOP reading with the Applanation resonance tonometer has been found to be affected by corneal biomechanical parameters. The diatom is a transpalpebral tonometer, and transpalpebral tonometry is based on measuring the velocity of a freely falling rod as it rebounds against the tarsal plate of a patient looking upwards, and the IOP readings with this device vary significantly from the intraocular pressure measured with the Goldmann Applanation tonometer and with corneal thickness, and it should be used only when conventional tonometry is not possible. The triggerfish is an approved contact lens for continuous IOP monitoring. It is a silicone contact lens with an electromechanical sensor. Indentation tonometry is typically done with the Sheard's tonometer. In indentation tonometry, the cornea is curved inwards, in contrast to applanation tonometry, in which the cornea is flattened. So the amount of intraocular volume displaced is more in indentation tonometry than in applanation tonometry. Sheard's tonometer is an indentation tonometer which estimates intraocular pressure from the amount of indentation of the cornea caused by a weight on the cornea with the patient in the supine position. Eyes with lower intraocular pressure are indented more, and the amount of indentation is measured by the amount of deviation of the indicator on a linear scale, and from this deviation the intraocular pressure is estimated with the help of a table. Indentation tonometry is affected by corneal biomechanical properties, particularly corneal rigidity, and it is no longer preferred, but it is the only tonometry method not to require electrical power. Digital tonometry with fingers, also called tactile tonometry, is very unreliable and is used only when other methods are not available, and it can only help us to detect gross difference in the intraocular pressure between the two eyes. Contact tonometers need to be cleaned immediately after every use to prevent transmission of infectious organisms, particularly viruses. Among the agents used to clean contact tonometers, sodium hypochlorite or dilute bleach kills more viruses than 70% isopropyl alcohol. Sodium hypochlorite is effective against adenovirus, but many studies show that 70% isopropyl alcohol is not effective against adenovirus, and it is recommended that after recording the IOP of a patient infected with hepatitis C virus, the tonometer should be dipped in 70% isopropyl alcohol for 5 minutes for effective disinfection. However, the possibility of transmission of prion diseases such as CJD is not prevented by any of these agents. And after disinfection, the tip should be rinsed with water and dried before examining the next patient to avoid corneal epithelial damage, and this is very important to remember. To recap the salient points, Goldmann equation relates intraocular pressure to factors which determine intraocular pressure, and they include aqueous humor formation rate, trabecular outflow facility, episcleral venous pressure, and uveoscleral outflow rate. Aqueous humor formation rate can be assessed by measuring total aqueous outflow rate with fluorophotometry. Trabecular outflow facility can be measured by tonography. Episcleral venous pressure can be measured by venomanometry, and Uveoscleral outflow rate can be derived from the equation when the other factors are known. Aqueous humor production is reduced by factors such as sleep, older age, and inflammation or hypoperfusion of ciliary body. Trabecular outflow facility is reduced by factors such as older age and inflammation and trauma to the trabecular meshwork. Episcleral venous pressure increases with supine position. Uveoscleral outflow facility decreases with age and is decreased by miotics, but can be increased by drugs such as prostaglandin F2 alpha analogs and cycloplegic agents. There is no cutoff intraocular pressure level which distinguishes between glaucoma patients and normal individuals. Still, IOP reduction is the only approved modality of treating glaucoma. IOP does not vary much with age. Factors known to increase intraocular pressure include supine position, bending, Valsalva maneuver, and eyelid squeezing. Factors known to decrease intraocular pressure include aerobic exercise and pregnancy. Diurnal variation of intraocular pressure in normal individuals varies between 2 to 6 millimeters of mercury, but diurnal variation is usually more than 10 millimeters of mercury in glaucoma patients. The intraocular pressure both in normal individuals and glaucoma patients usually peaks in early morning hours and immediately after waking up. Applanation tonometry is the most common method of measuring intraocular pressure and is considered the gold standard. In Goldmann applanation tonometry, the diameter of the corneal area applanated is 3.06 millimeters, and at this diameter, the outward force of corneal rigidity neutralizes the inward force of surface tension of the tear film. The endpoint of intraocular pressure measurement with the Goldmann applanation tonometer is that the inner margins of the two myoids should just be touching each other at the midpoint of their horizontal oscillation with ocular pulsation. Factors which may affect accuracy of IOP reading with the Goldmann applanation tonometer include corneal parameters such as thickness of the cornea, astigmatism, edema, scarring, and irregularity, myoid issues such as thick myoids, thin myoids or asymmetric myoids, eyelid squeezing, pressure on the globe, and inadequate calibration. Mackay-Marg tonometers such as tonopen and Pneuma-tonometer, both of which have a much smaller probe, can be used on normal areas of the cornea in patients with corneal edema and corneal scarring. They can also be used for a patient in the supine position, and Pneuma-tonometers can be useful in patients with keratoprosthesis. Non-contact tonometers use an air puff to indent the cornea, and they tend to overestimate the intraocular pressure compared to the IOP measured with the Goldmann applanation tonometer. Two tonometers, the eye care Rebound tonometer and the triggerfish contact lens tonometer, have been approved for home monitoring of intraocular pressure. Dynamic contour tonometry, applanation resonance tonometry, and transpalpebral tonometry are other techniques of tonometry. Indentation tonometry with the Sheard's tonometer is no longer considered a standard technique of tonometry as it is significantly influenced by ocular rigidity. Digital or tactile tonometry is highly unreliable and can be relied on only to detect gross difference of intraocular pressures between the two eyes. Thank you for listening.